purpose, Marie, what is the readiness challenge that you've been thinking about?
The readiness conundrum that I have been working on for a long time, actually, is the emergency room, and the emergency room being ready for people with diabetes who are coming there primarily for their diabetes. The problem is the emergency room will appropriately assess a person with diabetes as not needing to be in the hospital, and that person could potentially not get the next step in care that would be ideal for them so that they are okay to go home and not come back to the ER.
All right, welcome to the Dare to Be Ready podcast. This is the podcast where we explore the concept of readiness. This whole podcast is about how do we get ready? How do we get ourselves ready, our teams ready, our organizations ready to do the hard things that we need to do? This is a healthcare focused podcast, but we're going to talk about lots of different things and lots of different worlds and bring it all together. And we're going to have some amazing, interesting guests. Today, I will be here with my co-producer, James Lipshaw, and James is here. Hello, James.
Hey, Chris. Great to be here.
Great to be here with you. And we are also here with Marie McDonnell. Marie, how are you?
Great to be here. Thanks, Chris.
So good to have you here. Okay, and Marie is the director of the diabetes program at the Brigham and Women's Hospital. Marie, how do you say your title?
That's about right. And you can also add associate professor of medicine at Harvard Medical School. I teach the students there. But that's right. I direct the diabetes program at Brigham.
Great. I'm Chris Roussin. My role is I'm the founder of the CMS-ALPS team at the Center for Medical Simulation. And our team is called ALPS, Applied Learning for Performance and Safety. And we're interested in how to bring moments of learning to people and teams in healthcare, such that we get better every day and we perform as well as we can, and that our jobs feel like developmental experiences for us. And I work with a wonderfully talented group of people. Today, we are going to talk about readiness challenges in Marie's world. And we'll talk to Marie about that, and she'll introduce that to us. But what do we mean by readiness? I mean, let's broaden it out. How does a symphony orchestra get ready for its big performance such that it appears flawless despite doing something that's so difficult and so coordinated among so many people? And so we are here to explore issues of readiness, and we welcome you if you are a clinician in healthcare. We welcome you if you're a healthcare leader. We welcome you if you're training people in healthcare or otherwise, or if you're a present or past or future patient in the healthcare system. I think that about covers all of us. We think these conversations will be interesting to all of you. Let's get into it with you, Marie. It's your time. So,
Right.
yeah, can you tell us a little bit about your job and the scope of it? And then we'll ask you about what's the readiness kind of issue or challenge that we're going to focus on today.
Yeah, sure. I'd love to do that. So I'm a diabetes specialist. Obviously, I direct the diabetes program here. And one of my jobs is to take care of patients in the hospital as well as in the outpatient setting, which is, I think, where I see most of my patients. That's where we want them to be, not in the hospital, obviously. My job, I wear sort of two different hats when I'm doing that. Folks in the hospital, they're usually there for other reasons other than diabetes. So, surgical care or other conditions where their diabetes needs to be managed while they're there. And then sometimes, and we'll get to this, but sometimes they're there actually primarily for their diabetes, and so they can be put on different pathways depending on a little bit on readiness, which we'll talk about. The main thing that I do is organized care for people in the ambulatory setting, which is definitely a slower pace than the hospital. It's we have nine sites of care around the Boston area. The idea is a patient makes an appointment. Usually have to wait a few months to come in, and is part of that is they're learning how to manage their diabetes. We call that diabetes self management, and they get into like sort of a cycle where they're seeing different disciplines, nutrition, endocrinology, nursing, so that they know how to manage themselves. And it's a process. I sometimes tell patients, what now you have diabetes, it's now you have to sort of get a master's degree in it, and it takes time. Some people get a degree over several years. Some people are fitting it into night school and they're doing it as fast as they can or as easily as they can. It's sort of the same thing when you have a chronic disease like diabetes. So we have all this stuff organized in the outpatient setting. But, I think the challenge that every system faces when they're managing diabetes is folks who get into a little trouble. So
Yeah.
diabetes can be something that can, like most chronic disease, can kind of become a problem one day, and it can be a surprise. And we fitting that, I think every system struggles, including ours, in how to actually really be patient centered. Basically meet the patients where they're at all the time.
Thank you for that. Just to recap a few of the things that you said, it's good for patients to become knowledgeable in their own situation, understand what's needed to keep them healthy. Excuse my some of my terminology here. I'm a perfect layperson in this situation, and so the more knowledgeable the patient, the better they can take care of themselves and also request care. Is that fair to say? Was that in what you were saying?
Yeah, that's exactly right. And it takes learning even to get there. To
Okay.
learn what you need to learn is
Yeah.
actually is step one, and that can be actually the hardest step.
And Chris, I wanted to add my perspective, and part of my interest in this conversation is that I've been a type 1 diabetic since 1996, so almost 30 years now. So it's really fascinating for me to hear the readiness perspective from the other side, having a few decades now of patient experience.
Great, James. Okay, so wonderful to have you here in that expert capacity. And let's just keep clarifying as we go. One thing I want to say right now is when I came to healthcare, which was, wow, I don't know, about 12 years now ago, one thing I realized was, the hospital I went to work at Boston Children's Hospital, and I realized that the hospital was so busy and that people were so kind of fully scheduled most of the time or completely scheduled providing patient care that there were certain things that surprised me. And my education, I have a PhD in organizational behavior. I really focus on the social psychology of teams and groups at the workplace. Think a lot about trust and interactions between people and how that builds or degrades over time. And as I was looking at Boston Children's Hospital, I said, "Oh wow, these people, generally speaking, they don't warm up as much as I thought they did. They don't kind of have processes to like say hello and get ready before they work. I mean, they do some, but not a lot. And there's just not a lot of time for talking and preparing, not as much as I expected." Yeah.
You're right, and striking because there are attempts to do that, probably from folks like you, Chris and James, trying to get folks to huddle. We use that word a lot.
Yeah.
The huddle before the clinic session. So if you can imagine, you have a scheduled 15 minutes of looking at the patient panel that you have coming in the next 4 hours with a nurse who can potentially predict like be ready for something that we can predict
Yeah.
that might happen. Like this patient definitely is going to need a continuous glucose monitor. Let's get that ready. But what happens is I'll be on my way and then I get a page, right? And then I have to divert my attention to something that is more urgent by definition because it's a page. And you only page people if you need them like right away. So then that takes 10 minutes. And now we only have 5 minutes to huddle. And basically we say, you know what, forget it. You right?
Right. Right. And yeah, thanks.
That's what happens.
Right. And I noticed this as I would travel around the hospital. I did a lot of observing, and I was in charge of building a lot of training systems and simulation-based training systems in the hospital. But at first, I did a lot of observation and getting to know people. And I noticed that there was this shortage of time to warm up, to acclimate, and what I ended up calling mental rehearsal over time. And I think you were just describing a mental rehearsal. So here comes a particular type of patient. They're going to need, did you say, a continuous glucose monitor?
Yeah, it's a
Um,
little device they need. It'll take 15 minutes to teach them, but or maybe a little more, but it's better to be prepared because the nurse will disappear and do something else, and then you have to grab her back or him back. And
yeah.
if they know, like, oh, Mr. Smith's gonna, it helps so much. It would theoretically, right? But we have to be ready on a different level most of the time.
In my brain as I was working, actually, this concept of readiness started to really bubble up and get clear. I thought, what are the mechanisms of being ready for all the difficult patients, for lots of more normal patients, but more than you expected, for very complex things, for working across departments and across groups, which I know we're talking about today a bit. What are the mechanisms of readiness for that? And when I looked at the healthcare system, I actually started to see that it was under engineered around systems of readiness. That
Mm.
we do, and now this is all my opinion, with a lot of data, of course, but we fully task people and we don't give them time like a sports team would have to warm up, to practice, to run through drills every day, such that when the patients start coming through the door, we have drilled ourselves, we have warmed up, and now we're ready. Here they come. Of course, here they come. We're ready for them. And so we haven't given ourselves that luxury in the healthcare system. Start to notice that. That's the inspiration for what we're talking about in the podcast here, which is systems of readiness. And at the core of it is a construct called readiness planning. There is an open access paper, folks. You can go and you can look at what readiness planning is, or at least one angle on it that we've written about. Readiness planning basically says you take some time, just like a coach would for a sports team, or just like a leader of a symphony would, or a leader of a theater group. You take some time and you say, what do we need to be ready for? And obviously, if it's a symphony performance, you know exactly the piece of music that needs to be
Mm.
played, and you know exactly how various players factor into that. And so of course, you write that down. That's what you're doing. Um, Same for theater, same for many other applications. In healthcare, do we take the time to write down essentially the list of situations that our team needs to be ready for? The answer is no, we usually don't do that, almost never. And then, if you want it to be a little more discreet, inside of those situations that we need to be ready for and ready to achieve within, what are the core skills? If we were to extract the core skills out of those situations and make that list, what would that list be? And so, Marie, that's our basic construct of readiness planning. That's the get ready part of readiness planning. What are the skills we need to get ready with, and what are the situations we need to get ready for? And the idea is to bring readiness planning to healthcare around the world. That's really a big part of our passion. And so, and there's a little bit more to readiness planning, but that's really the heart of getting ready for things.
Makes sense. Really does. We need it.
Cool. So, towards that purpose, Marie, let's get on with it here. So, what is the readiness challenge that you've been thinking about as we've been getting
Mhm.
closer to this day?
Yeah, I love it. Yeah. So I think that there's two parts of this because you brought up the patient being ready, which I think should come up. I don't know how, but that we'll put that aside for a second.
Yeah.
Um, but and I know James knows what I mean. You know, patients have to be ready with diabetes. They have to be ready for when disaster strikes. But
Yeah, and when we get there, I'm sure we'll have a lot to say
yeah,
on that
exactly.
subject.
There. But the readiness conundrum that I have been working on for a long time actually is the emergency room and the emergency room being ready for people with diabetes who are coming there primarily for their diabetes, where they don't know, they don't either have the right, um, s- they don't know how to do something with their diabetes that could help them avoid a crisis. They're in a crisis already, and they don't have access to an alternative. and the emergency room's doors are always open. So it's a perfect place, and it's the appropriate place for an individual in a medical crisis to go. I think the problem is the emergency room will appropriately assess a person with diabetes as not needing to be in the hospital. They're actually okay. They need something like something short term, like maybe a little insulin, which they may get to eventually. But more importantly, they've assessed them to maybe just need some fluids, or and then they kind of there's a word in emergency room, they use the word triage, right? So they triage someone with diabetes to not be so sick, and that person could potentially not get the next step in care that would be ideal for them, so that they are okay to go home and not come back to the ER.
Mm,
So in diabetes land, we have a lot of ED recidivism. This is a word that the ED uses a lot. The concept is that, and they actually track it, by 72 hours, 24 hours, 72 hours, and then within the month. And it's people that were okay when they left the ER, but they come back in the same scenario situation. And so the ER kind of has to be, in my view, they have to be ready for triaging the person with diabetes who's so sick they actually do need to go to the hospital. But those who don't need to be admitted to the hospital, but they also need other things to make sure they are they know the next steps to keep themselves safe until they can get into that, what I mentioned before, this huge machine, which is diabetes self-management education, and follow up and medication management, which is like a huge commitment on the patient's part. But it's also it's, you can imagine, like a big building with a door that has like a special keypad, and you have to know the code. I mean, some people cannot get into that system for various reasons, insurance. It's difficult with their work schedule. So the ER has to get engaged somehow in connecting with people so they don't keep coming back to
yeah.
the ER. So that's my challenge. That's the challenge I've been working with the ER with for a long time, and others.
So at the heart, and you tell me if I'm wrong, at the heart of what we're talking about today is it's difficult for the ER, which has to be ready for lots of things. It's difficult
Yeah.
for the ER to be ready for patients with diabetes when they come in. There are mistakes that can be made. There are repeatable problems that are occurring, like people coming back over and over again in the same situation. And theoretically, there are ways for the emergency room team to be better ready for diabetes patients, such that the situation could be improved.
Yeah, that's it.
Fair to
That's
say?
good. Summarize. Yeah.
James, anything that I missed there you want to emphasize?
I do think it's interesting within this idea of triage with diabetes. The truth is that you're in many ways really sick all the time. You could come in and be in a state where you actually do need care immediately, and that's going to be obvious and you're going to be taken care of. But also, it could be, I need a juice box. and and if I don't get one, I'm going to be really, really sick. You get that and you're fine. But there's a whole nother system underlying that, which is like, how do we have this not happen tomorrow also, and the next day, and the next day, and the next day?
Exactly.
Because that's taking up so many resources that you don't really need because in theory, you should be able to manage it yourself.
And I don't know, Chris, we'll get to approach, but I'll just say in general, there are two approaches. There are three approaches to this, in my
Yeah,
view,
yeah,
that I thought about. One is the ER should have like a button they can press, whatever the theoretical button, where the diabetes care system pops out, and then they
yeah,
do everything right, and we write it up for them, and maybe a nurse who has special expertise always in the ER, who can
yeah,
say, oh yeah, I know how to do this. um, then the second option is to have diabetes specialists, like people like me, have like a SWAT team where they will go to the ER once they're paged to take care of, someone like James was saying, they got themselves into such a low blood sugar they needed to go to the ER. That could happen again in like 6 hours, unless that person unless somebody knows exactly why it happened and how to make sure it doesn't happen again. That takes a little, some special knowledge. So maybe a SWAT team. The
Yeah.
third option is you have this pathway that is super crystal clear for that patient to connect with that specialist team outside of the ER, which is kind of where all the stuff is. Like my clinic has all of the tools. They have the continuous glucose monitor. They have lots of juice boxes. They have, all
Yeah.
the things. So there are three ways. And so what everybody wishes is that the patient could get everything they need in the ER. And that would be the ultimate form of readiness. That's super hard for some areas of medicine where the ER is saying, listen, you know, I'm saving lives here. This patient, his life is okay. I gave him a juice box. I did my job. Can you expert people? Can you kind of do the rest?
Yeah.
Um, but I'll just say one thing about that, which is in our research, we found that a full 50% of people going to the ER because they're in trouble with their diabetes, they come after 5 p.m. And James, if you need an appointment with your endocrinologist, you can't call after 5 o'clock, right?
Oh, right.
You're gonna get a, do you need an urgent, nurse right now? Just, I got nothing for you otherwise.
I'm hearing a few categories of readiness, and what we're hoping to end up with is a couple items, Marie, that you feel are useful for you, maybe a bit more crystal clear. Um, but we're also hoping to give our listeners ideas for their own actions that they can take, whether it be specifically about diabetes care in the emergency room, or whether it be about something related or something this reminds them of. So I'm hearing the team in the emergency room, there are things that they can be more ready for. How well do we triage? How well do we provide care? How well do we connect with the specialist expert team and hand off or get advice? I heard in there, or maybe I'm assuming, how well we use our specific equipment, medicine, dosing, and all those things, which we can get into. Having worked at Boston Children's Hospital, variable doses based upon people's weight, size, age, and so on
Right.
and so forth was always
That's
such
right.
an issue. But I'm also hearing readiness for coaching and counseling when people leave something I developed a passion for during my time at Boston Children's and just working in hospitals in general is the importance of moments of discharge, and how if we educate people as we discharge them and they actually understand it and they actually engage in a learning moment, how enriching that can be, how much that can help them help themselves. And if we miss that opportunity, how much we lose there. Then I was hearing you refer to kind of coaching and counseling as we discharge folks, and how if we don't do it, there's a lot of risk of just repeating the same darn things over and over again. What do you think is a ripe kind of central focus for us here? And we're going to bring a lot of empathy, as we always do. The emergency room, hard place to work, lots of patients, really complex, lots of exhaustion, patients and clinicians alike. What's a good centerpiece for us to focus on related to emergency room readiness for diabetes patients?
Yeah, that's a really good question. I think because there are two sides, which is the triage, making sure that the ER knows who's in trouble and who's not. I actually think the ER, that's what they do really well, right?
Uh-huh.
So um, I think it's the next step of uh, after a patient is stabilized with diabetes, the ER needs to be ready for the appropriate next step. And right, James, like how what should the counseling isn't the only thing. It's treatment too. So but it's what I think is variable, and folks don't know what to do often. So it's the next step after stabilizing a patient. And a lot of times it's patient, we know that patient's going to the hospital. That's actually not a really contentious issue at all. I think insulin therapy is very protocolized, Chris. We
Okay.
even do have weight-based insulin protocols that the ER probably does better than everyone else, just for the folks who are in trouble. These are folks they have. what we call hypoglycemic crisis. They do such a great job identifying. I think it's the everyone else that we could focus on. It's folks who can leave the ER. They're safe to go home from a perspective of the lab tests look good and they're awake and alert. That's where I'd love to talk about.
Hmm.
Um, how does the ER know? Should they give an insulin dose to that person who's going to leave? That's
Uh-huh.
something that's an interesting, believe it or not, question. Um, should they? Should what Are they responsible for giving guidance on next steps? And then how much do they need to understand about what the patient's dealing with? A good example is diabetes is super techy now. I was just consulted in the ER. It was like Friday at 6 o'clock, and I thought to myself, "Thank God I'm here," because our fellows don't even know about insulin pumps yet. They're just brand new, right? We're in July. We have really new doctors.
Right. So July's the time when the new fellows arrive.
New fellows arrive, and this
Yeah.
young woman came in with a pump malfunction, an insulin pump malfunction, super technology. And there was really no one else that could have gone to the ER and helped her than me. At that very moment, it just happened to be Friday at 6 o'clock. I was really the only person at Brigham Women's Hospital that would, other than maybe if a patient was around who could, of course, you can't consult another patient. And I was just thinking to myself, you know, that's not great, right? I was on my way home,
Hmm.
and they really didn't have a good set system for helping this woman she was safe, uh, but you know, she didn't really have the super confidence to say, yeah, yeah, no, my pump is fine now, or whatever what needed to happen.
Yeah.
Yeah, I the technology stuff is crazy, and it's fascinating, and this will probably fit in under how do you get patients ready. It's the technology is very complicated. Some of it is just like any other technology, it just breaks sometimes. Like sometimes it just doesn't work. I'm connected to my pancreas via Bluetooth, essentially. Like that's not great.
Problem.
um, like
Problem.
sometimes you sleep in the wrong direction. It's like, oh yeah, we lost Bluetooth connection at 3 a.m. Sorry. You'll go to replace something, and the first question from the manufacturer, which is who you have to go to when you have a device
Yes.
problem, you have to go back to the manufacturer, is did you have to go to the ER for this? Is
Wow.
always the first question on the form when you request a replacement.
So if we take this moment and we get real practical around a readiness step or a readiness planning step, we would try to take a readiness goal or create a readiness goal. And a readiness goal was worded like this: we want fill in the blank people to be ready for fill in the blank thing, or ready to do fill in the blank thing in a particular situation. And so, Marie, if you're gonna have to be the expert here, but you were talking about, triage goes pretty well.
Yeah.
Although if we train people to beautifully recognize and triage patients with diabetes, always a good thing. But it's that next moment after they've been stabilized, I think was the word you used, diagnosing like what's your next care move. So you want ER staff? Are we talking about nurses or doctors or anybody in the ER?
I think both.
So we want ER doctors and nurses
Yeah.
to be ready to.
Yeah. Ready to transition a patient who is stable with diabetes, who is stable, medically stable, to a I mean, the word safe comes up in my mind,
Uh-huh.
but I think that's fair. To a safe medical plan. I don't know. Safe is a little wishy washy. Like appropriate, like effective, appropriate. It's essentially like you said. It really is discharge planning, but
Uh-huh.
it's unique because it has to be focused on stability. Until they get plugged into usual that ambulatory care system that I mentioned.
Great, Marie. So when we're making readiness goals, we have these messy first drafts, and that's
Yeah, I bet.
good. That's
I bet.
really good. And right now we're working without a whiteboard here, but you just played around with a first draft. So I'm going to ask you to use maybe a notebook or a screen or something to
Sure,
craft
sure.
your next draft. Okay.
Yeah,
Working on a first draft of a readiness goal. And a readiness goal is it's a really cool, actionable thing to a nerd like me, of course. But
yeah,
readiness of which people to
yeah.
perform well in what situation, okay? Or readiness of which people to recognize and manage well in what situation. And so we started out with a bit of a global statement about doctors and nurses in the emergency department being ready for transition and or discharge decisions with a diabetic patient. I like, Marie, you were tempted to put a quality word in there. You were like, safe might not be the right word, but it's a really good thing in a readiness statement to have a quality, what we call like a quality indicator, like
Hmm.
successfully do it or do it according to best practices or something.
Oh,
And you were having that urge, and I think that's a really good urge.
okay.
So where might
Um,
you take this as a next draft?
right. I know. The issue is maybe, more general versus more specific. Because I was,
Yeah.
and I don't know how specific we want to get, but you know, t- just this conversation has made me think that like somebody in the ER who has diabetes special knowledge, like a nurse champion or a nurse diabetes resource nurse. Um, but anyway, that's very specific. But the idea that there'll be expertise that is ready at all times to transition a person with diabetes out of the ER with a safe management plan.
Now,
Okay.
you asked how specific or how general. We want this to be actionable for you. So this,
Actionable.
yeah,
Yeah.
the readiness statement helps us make decisions about training
Okay.
plans or investments, inviting people over for a seminar, you coming over there, giving a workshop, helping them with scheduling of people. How can I help you train such that you do have an expert on every shift? So this readiness statement, it's really it's our readiness, it becomes our readiness requirement, this readiness goal. And it helps us make decisions about what we do for workshops and training and scheduling and kind of preparation of the creation of that readiness, basically.
Do you have your readiness statement at the end of it? Say it's I always ready to
Yeah.
blank. That this person always has to be ready to blank in order to, like, do you have an outcome at the end, or that's not?
It's so I always encourage wordiness is good, especially in the early drafts of these readiness goals. Like say which
Okay.
people you want to be ready for what and why.
I would like the emergency room team to always be ready to transition a person with diabetes from the emergency room with a safe medical plan in order to prevent them from coming back to the emergency room.
Great. Okay, so that's a really clear readiness goal. Now, okay, so now what's our job theoretically? And my team does this kind of work all the time, but our job is to think, well, what's the project that we would do to actually create that readiness?
Right.
And the the pivot that we've found that is the most important thing is the concept of partnership with our partners. So who are the partners and what will we do together in order to create this readiness? So who are the partners? I mean, I assume you'd need to team up with the emergency department team and maybe people on your team. Like who are the partners and why are they the right partners to think about this readiness problem and kind of what to do about it?
Right, exactly. Yeah, so partnering with the emergency room is huge for this. Making it pretty formal, right?
Yeah.
Because we always have on on some level partnership in the hospital system. If anybody can call me and page me and say, I'm a radiologist and you're an endocrinologist, I need your help. But that's different. That's like a commitment to being, available and sharing your expertise in the moment. Yeah, so a partnership, I would say, with the emergency room administrator
Okay.
who could, put forth change, and maybe think it through, and also just making sure you involve nursing, because sometimes we find in partnerships like you're pointing out, the doctors start talking, right? And if a lot of the work falls in other disciplines and they're not involved early on, you just make a lot of mistakes. Maybe even a partner, like a nurse partner on my end, potentially could partner with a nurse partner on their end.
I think if you don't have a shared urgency among all those groups around this actually being an issue and something you should solve together, then you can go no further if you don't create that shared sense of urgency, really.
That is such a, I just want to call that out as such a huge point because I think this problem came to me a long, long time ago, but it was because an emergency room physician called me at 8 p.m. and said, "We have a lovely person with new onset diabetes." So this is a person who
Hmm.
didn't know they had diabetes, right? There's like
Right.
James when he was first
Yeah.
diagnosed. It's like really scary. And it was 8 p.m. and I was a junior doctor, and he said, "So what are you going to do for this kid?" And I said, "Well, what are you going to do for this kid?" And then we realized that we need to partner because nobody knows what to do, and this is such an important critical moment for this young person. I think that that was a click moment for me that we both had the shared urgency, but we had nobody was ready. No, neither of us were ready.
Yeah, amazingly, my parents actually never took me to the hospital, but that's a whole nother story. Uh, but no, I think that working through that outcome really is going to help in this moment because I can't imagine going to emergency department personnel and saying our outcome goal is fewer people coming into the emergency department and them saying no, we're not interested.
That's right. That's exactly right.
Maria, I love what you're saying. We're going to close up the podcast here with what we call our call to action. So, everybody that's been listening, you've heard us, and Marie's really generous leadership today and context. You've heard us work through an issue and get to what we call a readiness goal or a statement about what the readiness that's important and how clarifying that can be. We want that emergency room team to be ready for certain things in certain moments and for a very specific reason. And now we're thinking about, well, what do we do about that once we have that readiness statement? Marie's walking through who should I partner with, who should I talk with, and then the next question really is what do you do? And that could be create training programs to get certain people ready with skills and give them some situational practice, which simulation's great for that. You can do that with role playing and you can also do it with classroom learning. You can at the very least make videos about it that people can watch. There are all kinds of great tools. Ideally, all those things together creates the best program. If you work that readiness project and make it sustainable, kind of build it into the culture of the emergency department and the diabetes program, this is something you do together to create continuous readiness in the emergency room. And that actually becomes very satisfying. And also something that I think healthcare isn't great at, right? These cross-departmental collaborations. We don't budget for it. It's not a formal part of our work process. So Marie, maybe as some of your closing thoughts here, what are the hurdles that you'll have to kind of overcome and how might you overcome those? Can you just call these folks up? Does everybody have time to partner in these ways?
I've actually created some pathways already, but they're not 100% successful. So the partnership part, I think, is somewhat the easy part in the sense that once you get that done, like you were pointing out, it's then you have to figure out what to do. But there's definitely mutual urgency. I think everybody's on the same page. I guess I always call it aligned incentives. Everybody's completely aligned to help that
Yeah.
patient at 8 p.m. leave the emergency room because they don't need to be in the hospital, but they really are not safe until somebody does something. The hurdle for the ER is recognizing this as something that is part of their space. That it's really integral to what they do. That's kind of hard. I can't dictate what the ER should focus on and what their scope is. But I do know that they're aligned with helping this person's be safe and not have to come back. So it'll be sort of training, who does on their end, who does what, and what on our end, what do we do? And it's a combination of both. I think what I think as I'm thinking about next steps for, for us and for anybody doing this is really to determine what the ER thinks they could provide. What kind of support, for example, a nurse champion, or resource nurse for diabetes. Because if the prevalence is high enough, and that's something we should figure out too, if the prevalence of these folks is high enough, then that makes sense for the ER to devote resources to. Um, Otherwise, we'll really have to focus on that pathway out of the ER. No matter what time the patient comes in, the pathway is like lit up in front of them, which is the biggest challenge.
That sounds amazing, Marie. We'll check
Yeah.
in with you over time and see if you have anything that you want to update us on. James, I'd love for you to let our listeners know kind of how we want to hear from them and maybe how what they tell us might be used.
Yeah. So if folks would like to chat with us, if they have stories they want to tell us, if they want to tell us about the ways that they're implementing readiness in their own spaces, if they're clinicians or working in other fields, the best thing to do is to just comment wherever you found this video. So whether that is on YouTube, on LinkedIn, you can find us at Center for Medical Simulation on social media. Also, if you have a specific question you want to ask us, you can always email info@harvardmedsim.org.
Thank you, James. Folks, we would love to hear from you. I imagine over time that some of our honored guests will actually come from our listener base, and we're very much looking forward to that. Marie, thanks again for working through this readiness challenge. You do amazing work.
Thank you so much, both of you. This was a lot of fun.
All right, we'll talk to you soon. Take care, everybody.